So dear students, welcome to the class on human scalp. I am Dr. Gaurav Agnihotri. So what is the meaning of the word scalp? It refers to soft tissue layers covering the skull cap. The other name of skull cap is cranial vault or calvarium. And there are boundaries of the human scalp. Anteriorly, it extends from the supraorbital margins to posteriorly the external occipital protuberance and superior nuchal lines. And on each side, the scalp is demarcated by the superior temporal lines. So let us see these boundaries of the scalp on the skull now. So supraorbital margin, that is here, and external occipital protuberance, that is at this level, and superior temporal line one can make out here on the lateral aspect of the scalp. So these are the boundaries of the scalp. If you look at the occipital bone, here one can make out the external occipital protuberance, and extending on either side of the external occipital protuberance is the superior nuchal line. So the posterior aspect of the scalp is limited by the external occipital protuberance and the superior nuchal lines. So students, you must know the boundaries of the human scalp. Now we come to the layers of scalp. So SCALP, each alphabet in this word, it corresponds to a layer. From outside to inside, S stands for skin, C stands for connective tissue, A stands for aponeurosis, L stands for loose areolar tissue, and P stands for pericranium. So these are the layers of the human scalp. Now coming to the first layer, that is the skin. The skin is thick and hairy. Due to abundance of sebaceous glands, the scalp is a common site for sebaceous cysts. In this figure, we can see the sebaceous cysts in this patient. So the skin of the scalp has got hair, and in relation to the hair are lying the ducts of sebaceous glands. When these ducts are blocked, then it leads to formation of sebaceous cysts. Next we come to the connective tissue layer. Now this connective tissue layer is the medium for passage of nerves and vessels to the skin. Now some features of this connective tissue layer: it has a rich blood supply. So due to this rich blood supply, that is blood vessels, due to the presence of blood vessels in the connective tissue layers, when a portion of scalp is torn, it can be replaced in the original position and stitched. The blood supply, the good blood supply of the scalp, due to blood vessels in the connective tissue layer, it ensures quick healing and recovery in case of torn portion of the scalp. So whenever there is a tear in the scalp, it is prudent to just replace the torn portion back to its original position and stitch. So what happens is, once this is done, the good blood supply of the region ensures early recovery. Other thing about the connective tissue layer is that there is a lot of bleeding if there is a wound in this area, because the vessels are prevented from retraction by the fibrous fascia. So this connective tissue layer has got a good blood supply, but there is a lot of bleeding from this connective tissue layer because of the presence of fibrous fascia. This fibrous fascia prevents retraction of the blood vessels present in the connective tissue layer of the scalp. And the bleeding from the scalp, from the connective tissue layer, it can be stopped by applying pressure against the bone. So you can see in this figure, there is bleeding from this area of the scalp. So a cloth is kept here, and then pressure is applied on the cloth by the doctor to stop bleeding from the scalp. Other thing about the connective tissue layer is that the fascia is dense. So due to the density of the fascia, the inflammations, they cause little swelling but a lot of pain. Because the fascia is so dense, there is no area for swelling to take place, but at the same time there is a lot of pain. So about the connective tissue layer, students, you must know that the blood supply is rich in the connective tissue layer. The wounds, they bleed profusely because fibrous connective tissue prevents retraction of blood vessels, And due to the dense nature of the connective tissue, the hemorrhages, they are never extensive, but the swellings, they cause a lot of pain, although they are not of huge size. The swellings are not massive, but they cause a lot of pain because of the dense nature of the connective tissue in the scalp. So again, we see here the connective tissue layer, and in the bracket is written dense. So the dense nature of the connective tissue is there. So swellings are not massive, but they are painful, and one can see the blood vessels in the connective tissue. Now the next layer is the aponeurosis. Now aponeurosis is a modification of deep fascia. So the aponeurosis in relation to the scalp is called epicranial aponeurosis or Galea aponeurotica. So this Galea aponeurotica or the aponeurosis of scalp also has got boundaries. Anteriorly, it blends with the eyebrows and receives insertion of the frontalis muscle. Posteriorly, it receives insertion of occipitalis, the occipital bellies, and posteriorly this Galea aponeurotica is attached to external occipital protuberance and to the highest nuchal lines. On each side, the aponeurosis is attached to the superior temporal line, as we did in the extent of the scalp, but you should note here that this Galea aponeurotica sends down a thin expansion which is attached to the zygomatic arch. We'll come again to this expansion when we talk about the superficial temporal region. So the third layer is the epicranial aponeurosis. I will describe again this layer in the by taking a diagram into consideration. So here one can make out the frontalis muscle. So this is the Galea aponeurotica or the epicranial aponeurosis. So anteriorly it is going up to the level of the eyebrows, and posteriorly, see, it is getting attached to the highest nuchal line, and then occipital bellies are there, so it's merging with the occipital bellies. So this is the Galea aponeurotica. Now the frontal bellies are lying anteriorly, there is less gap between them. Occipital bellies are further apart from each other. The frontal bellies are supplied by the temporal branch of facial nerve. So we say the frontal belly of occipitofrontalis muscle is supplied by temporal branch of facial nerve, while the occipital belly of occipitofrontalis muscle is supplied by the posterior auricular branch of facial nerve. So this diagram is showing the occipitofrontalis muscle and the Galea aponeurotica or the epicranial aponeurosis. So the frontal belly of occipitofrontalis arises from the skin of forehead and is inserted into the epicranial aponeurosis. As I mentioned, this is supplied by temporal branch of facial nerve. Now what is the function of the frontal belly? It raises the eyebrows and causes horizontal wrinkles in the skin of the forehead. So there is less gap between the frontal bellies. So we can use the term frontal belly of occipitofrontalis. The occipital bellies are small and separate. So each arises from lateral part of superior nuchal line and is supplied by posterior auricular branch of facial nerve. And the thing about this Galea aponeurotica is that the wounds of the scalp do not become wide open. They do not gape unless epicranial aponeurosis is divided transversely. So in case the division is only of the skin or the connective tissue, then the wound will not become wide open, but it will become wide open only when the Galea aponeurotica is breached. So, and that too transversely. So gaping wounds of the scalp are due to the involvement of the Galea aponeurotica, and it is breached transversely, or it is divided transversely. Next we come to the loose areolar tissue. So this is a layer which is important from an examination point of view, because loose areolar tissue is called the dangerous layer of the scalp. Now anteriorly it extends into the eyelids. Why? Because the frontalis muscle, the component of occipitofrontalis belly, So that frontalis muscle has got no bony attachment. So anteriorly the loose areolar tissue, the loose tissue of the scalp is extending into the eyelids. Posteriorly it extends to the superior nuchal lines, and on each side it extends to the superior temporal lines. Now why this is called dangerous layer of scalp? Because emissary veins open here. Now what are emissary veins? They are veins connecting veins inside the skull with those outside the skull. Now emissary veins open in this fourth layer, and they may transmit infection from the scalp to cranial venous sinuses, leading to serious complications like meningitis. So any infection which involves the fourth layer, because of presence of the emissary veins here, those veins can transmit infection to inside of skull into the cranial venous sinuses, and that can lead to serious complications like meningitis. Also, the loose nature of the fourth layer allows easy spread of pus and blood, further increasing the risk of infection. So that is why this layer is called the dangerous layer of the scalp, because if infection is there, it can go and spread to inside of the skull and involve the cranial venous sinuses, causing meningitis, which is a very serious complication. Also, since this layer is loose, it facilitates the spread of infection and the blood. So further it accentuates the risk of infection. So you must know about this layer in detail, students. Loose areolar tissue, why it is called the dangerous layer of the scalp. Now I told you loose areolar tissue extends anteriorly into eyelids because the frontalis muscle has got no bony attachment. So another aspect of this loose areolar tissue you should know is that collection of blood in the loose areolar tissue causes generalized swelling of the scalp, and this blood may extend anteriorly into the eyelids because the space is open here. So loose areolar tissue is continuous with the eyelids, so any blood collecting in the loose areolar tissue can gravitate into the eyelids, causing the black eye. So one should know about the anatomical basis of black eye. So loose areolar tissue is important because of two things. One, it is the dangerous layer of the scalp, and two, because of we can explain the anatomical basis of black eye based on the anatomy of loose areolar tissue. And the fact is, the loose areolar tissue, it is continuous with the eyelids anteriorly, so blood can collected blood in the loose areolar tissue can gravitate into the eyelids, and this forms the anatomical basis of black eye. So loose areolar tissue is important because it's dangerous layer of scalp, and because when we know the anatomy of loose areolar tissue, we can explain the anatomical basis of black eye. Next layer is the pericranium. Now pericranium is the periosteum of the skull bones. So this layer is loosely attached to the surface of bones but is firmly adherent to the sutures, that is the junction between the bones. As the pericranium is adherent to sutures, collections of fluid taking place deep to the pericranium are referred to as Cephalhaematoma. So one should know this layer to explain the anatomical basis of Cephalhaematoma. So what is Cephalhaematoma? The collection of blood deep to the fifth layer of scalp. And since the fifth layer of scalp is firmly adherent to the sutures, so this collection of blood does not cross the suture line. So that collection of blood deep to the pericranium is referred to as Cephalhaematoma. And this needs to be distinguished from Caput succedaneum. So what is Caput succedaneum? So Caput succedaneum versus Cephalhaematoma. So in Caput succedaneum, what happens is that there is soft tissue injury to the scalp during delivery. So here the fluid collection is superficial to the periosteal layer. While in Cephalhaematoma, the fluid collection is deep to the periosteal layer. So you can see on this side. And since the periosteal layer is fused to the suture lines, the swelling does not cross the suture lines. While in Caput succedaneum, the swelling is of soft tissue layer, and since it is lying superficial to the periosteum, this swelling, it crosses the suture lines. So during delivery, the swelling may occur. Now, whether this swelling is caput succedaneum or Cephalhaematoma, one can make out by finding out whether this swelling has crossed the suture lines or is confined to the suture lines. And once we come to know that it is not crossed the suture lines and probably it's lying deep to the pericranium, then we can label the newborn as having Cephalhaematoma. So one must know the anatomical basis of the difference between caput succedaneum and Cephalhaematoma. So this is the importance of the fifth layer of scalp, that is the pericranium. Now we come to the superficial temporal region. So what is superficial temporal region? So this is not a part of the scalp because this region is a different region. It is the area which lies between superior temporal line and zygomatic arch. And this area has got 6 layers instead of the 5 layers of the scalp. First layer is the same skin, second layer is the same superficial fascia, third layer, as I mentioned when I talked about epicranial aponeurosis, there is an extension of epicranial aponeurosis in the superficial temporal region. So this forms the third layer. Fourth layer, instead of loose areolar tissue in the superficial temporal region, we have the temporal fascia. And the fifth layer is the temporalis muscle. And then we have the pericranium. So superficial temporal region, what is that region? That is the region which lies between the temporal line and zygomatic arch. So this is the superior temporal line which limits the scalp, and this is the zygomatic arch. So when we talk of superficial temporal region, we are talking about this area, and this area has got 6 layers instead of the 5 layers present in the scalp. So when one is asked about the scalp, the examiners also tend to ask about how many layers are there in the superficial temporal region and where is it located. So one should know. Now we come to arterial supply of scalp. So before describing the arterial supply, I must mention that the scalp has a rich blood supply derived from both internal and external carotid arteries. These two arterial systems anastomose over the temple. Now the question arises, what is the meaning of the word temple? So temples are flat areas on the sides of the head between the forehead and the ears. So this is the forehead and this is the ear. So this is the temple area on the sides of the head. The temple area corresponds to the location of the bony component, that is the pterion of skull. So temple is one area where there is anastomosis between internal and external carotid arteries. So these two systems, they anastomose in the temple region, and these two systems also, the internal carotid system and the external carotid system, they also anastomose in the scalp area. We will see how. So this is a diagram which you should know from an examination point of view, the arteries and nerves of the scalp. So now if I talk about the arteries here, we have got the supratrochlear artery and the supraorbital artery. On the medial side, we have supratrochlear artery. Now this is arterial supply of one side of scalp. So we have got supratrochlear artery, and then laterally we have the supraorbital artery. Now students, both these arteries are branches of the internal carotid artery. And then we have this superficial temporal artery, posterior auricular artery, and occipital artery. These three are the branches of the external carotid artery. So internal arterial system, that is branches from these two arteries, they anastomose with the external arterial system, that is branches of these three arteries in the scalp. Also, I mentioned earlier, in the temple region, the internal carotid and the external carotid systems, they anastomose with each other. So somebody asks you two sites where internal carotid and external carotid systems anastomose. You can safely answer scalp and the temple region. Now we talk about the nerve supply. So there are 10 nerves. So 5 are in front of the auricle and 5 are behind the auricle. And out of these 5 in front of auricle, 1 is motor. Out of these 5 behind the auricle, 1 is motor. So let us see which nerves are there. From the front, we have supratrochlear nerve, supraorbital nerve, temporal branch of facial nerve. Now this is supplying the frontal belly of occipitofrontalis. So this is the motor branch. And then we have got the zygomaticotemporal nerve and the auriculotemporal nerve. So temporal branch of facial nerve is the motor nerve in front of the auricle, while the remaining nerves, they are sensory nerves. And behind the auricle, we have got the posterior division of great auricular nerve, lesser occipital nerve, the posterior auricular branch of facial nerve, greater occipital nerve, and the third occipital nerve. So there are 5 branches behind the auricle, and out of these 5 branches, the posterior auricular branch of facial nerve, it supplies the occipital valley of occipitofrontalis. This is the motor nerve. Remaining nerves, they are sensory nerves. So students, you must know this diagram and you must know the root values of the nerves where they are mentioned. So this is what you need to know in this diagram. 4 sensory nerves in front of auricle, 4 sensory nerves behind the auricle, 1 motor nerve in front of the auricle, 1 motor nerve behind the auricle. So in total 5 nerves in front of auricle, 5 behind auricle. Total number of nerves are 10. So the 5 nerves in front of auricle are mentioned here. This is the motor nerve. 5 nerves behind the auricle are mentioned, and see this greater occipital nerve is the thickest cutaneous nerve of the body. Do not miss this point. Okay, which is the thickest cutaneous nerve of the human body? It is the greater occipital nerve. So you can view the theory related to today's topic in my book, Head and Neck Gross Anatomy Notes by Dr. Gaurav Agnihotri. It is available on the Buzz Desire platform. You have to log in and register, and you can view the book and many other books which are available there. So the theory can be studied from that platform. Once you do the scalp, you need to do the norma verticalis and other normas also. So you can go to the YouTube channel and there you can open the playlist of head and neck. The link is provided here. So from there you can study the exterior of the human skull. And this will help you in understanding the osteology of the human skull. So thank you for your time. Till the next time we meet, it's bye from my side.